Here, Dr. Vanita Pathak Rai. The topic is phacoendocycloplasty versus phacotrabeculectomy in primary angle closure glaucoma, result of a pilot study.
Thank you and good afternoon. These are my co-authors. We all know trabeculectomy is the gold standard, but also we know that complications can occur. There are at least 2 very large studies which have shown complications to the tune of 40% or more. So in the quest to find newer treatments, we propose phacoendocycloplasty. We know cataract surgery alone can increase angle recess in angle closure, but in plateau iris syndrome, this is not so, and there has been some recent evidence of this. Given the fact that there are a few studies now of phacoendocycloplasty in plateau iris syndrome and our own experience with a pilot study, retrospective pilot study, where I have studied 10 eyes for 18 months, where median IOP, AGM, as well as visual acuity, all statistically were different with no serious complications, we set about to investigate the efficacy and safety of this compared with trabeculectomy when it is combined with phaco in medically controlled and uncontrolled angle closure disease. This was registered with CTRI, it was IRB approved, and informed consent was taken from all patients who were eligible for standard indications for combined surgery. All patients with secondary glaucoma, previous intraocular surgery, one-eyed subjects, and any advanced glaucoma field defects were excluded. Phacoendocycloplasty was done through the phaco wound. The probe is inserted, and power is set as 500 milliwatts and time of 2000. We aim at the tail of the ciliary body such that the whole ciliary body contracts away from the iris. Phacotrabeculectomy was a standardized operation. Both were accommodated superiorly as separate site, and mitomycin C was used, sponge application, not 0.04 milligram per mil, not 0.4 milligram per mil for 2 minutes. And there was a standardized regime of drugs as well as post-op follow-up in both groups. The primary outcome measures were intraocular pressure, secondary were anti-glaucoma medication, best corrected visual acuity, and complications, complete success and qualified success, greater than 5 millimeter mercury, less than 18, with or without medication. We had 42 eyes of 37 patients, 20 in the phaco-trab group, 22 in the phaco-ECP group, 2 in the phaco-ECP group were excluded, unfortunately, because laser was not done as per protocol. Median follow-up 11 months in the phaco-trab and 8 in the other group, 8.5 months in the other group. Preoperative characteristics were all very well matched. We extensively searched for parameters. In the phaco-ECPL group, compared to preoperative, postoperatively at last follow-up, all parameters were statistically significant. Intraocular pressure and AGM was reduced, and visual acuity was increased. So the same happened with the phaco-trab group. When we pitted both of them together, what we found was that these parameters were not statistically significant. They changed, but between them, they did not change. So you can see in this graph that around 3 months is where the difference is minimized. There was no difference in this success between the two groups, statistically significant. This is endoscopic view of the angle where pre-ECPL, endocycloplasty, and after phaco, you can see that only 1 clock hour of angle is visible. Post-endocycloplasty, where we target the tail of the ciliary process, which you see in a minute, yes, the angle then opens up completely, and you can see scleral spur. And when you compare the two together, this is what you see. This, we also got evidence in terms of intraoperative anterior segment OCT, where we found that compared to pre-phaco and even post-phaco, the post-phaco ECPL angle recess was much larger. So what is it that separated the two? It was in the number of complications. And most of them in the postoperative period tended to be bleb-related complications. And not only the complications, but even the interventions were statistically significantly different. So as proposed here, we hypothesize that it's not only the increase in angle recess, but also the photocoagulative effect, which is very important. So far, studies have mainly concentrated on open angle as well as in refractory glaucoma. The ECP collaborative study has found a very low rate of hypotony, and this is therefore different from the transscleral delivery of the same, where hypotony and visual loss is not uncommon. So the advantages of this is that not only does it have low risk of hypotony, post-operatively the eyes are quiet, it is quite safe and repeatable, and most importantly, the conjunctiva is virgin, and if you need to do a trabeculectomy later, it's not a problem. This advantage is the cost. Here is a photograph of a post-phaco-ECPL eye on top. You can see at 1 week how quiet it looks compared to phaco-trab 1 week at the bottom. Therefore, we conclude that this pilot study suggests that phaco-ECPL is as efficacious as phaco-trab, but appears to be safer. It does merit further investigation, a full-fledged investigation in angle closure disease with longer follow-up. Thank you.
When you chose your subjects for the cyclophotocoagulation, did you differentiate between an angle closure and a plateau iris?
No. We did have post-LPI occludables in both groups, and this was statistically insignificant.
That's fine, but did you look particularly for plateau iris in that group, or it was there, or it was not?
No, it was there. It was there. Yes.
Was there a difference between the results in the angle closure and the plateau iris?
It's too small. It was just a pilot study to make sure that we are efficacious enough, but also quite safe.
How many quadrants were you treating?
We treated just over 2 quadrants, which is what you can get from one phaco wound. So about 220 to 270, between 30 to 35 ciliary bodies.
What does the cost come to, Dr. Vineet?
Well, I look at it this way. We all changed to phaco, and we bore the cost of phaco because it was better. I feel endocyclophotocoagulation is better, so we should bear the cost of this too.
Thank you.